Thank you, Giorgio. Thank you, Luis, for your invitation to come here. It's a real pleasure to be in Madrid, one of my favorite cities. Although I am from Barcelona, I did my surgical training here. It's always a pleasure to come back. The topic is the new TNM classification, and I just want to show you this slide to let you know that the 8th edition did not come from nothingness. So there is a history in it. Actually, we've been working in the ISLC for more than 20 years. The original idea was in 1996, and the ISLC has been responsible for updating the two latest editions of the TNM classification. For the 8th, we followed more or less the same timeline as we did for the 7th edition. We are in 2017, where the 8th edition has already been published in the classical manuals of the AJCC and the UICC, and also in the 2nd edition of the ISLC staging manual in thoracic malignancies. So the classification is out there. All the recommendations suggested by the ISLC has been accepted by the American Joint Committee on Cancer and the Union for International Cancer Control. This is the group, the last meeting in Vienna. The group is being revised now. About 2/3 of the people you see there will leave the group and others will come. Some people who's been in the advisory boards will be upgraded to the membership of the staging committee. But most important is that behind this group there is a greater group of people working in their institutions that have submitted for free their data to the ISLC database. And they do it voluntarily. There is no payment for their work and efforts, and this is thanks to them that we are here today. We can be here today discussing the 8th edition of the TNM classification, which is one of the few classifications that is really based on data. Others are based on opinions of particular institutions, publications of limited number of patients, but this this 8th edition is based on nearly 100,000 cases, most of them coming from Europe and Asia. For the first time in the history of the TNM classification, we have data from South America. For the 9th edition, we will have cases from Africa, as our colleagues from Casablanca are already registering cases of lung cancer, most of them advanced disease. After exclusions, we had 77,000 patients available for analysis, and this slide is important because it shows the nature of the data. Most data are retrospective. That means that institutions around the world had their own databases, and that just with a click, pressing a key, they could send their databases to the CRAB, Cancer Research and Biostatistics, which is the agency that manages and controls and stores the database for the ISLC. But these retrospective databases had the detail on the TNM descriptors that we needed for the revision. However, the smaller database, that prospective database, which means that somebody has sat at a computer and registered online all the fields that are required for the revision of the TNM classification, did it for nearly 4,000 times. And this smaller but more detailed database has been very useful, as you will see later, to say something new about the M component of the classification. Most patients that have been registered for this edition underwent surgical therapy, 85% or a little bit more. This does not reflect what we see in clinical practice, where at most 20% are resected, but this is what we have. For this edition, we had many surgical series. We did not have clinical trial series, but the smaller group of patients whose tumors were classified clinically only were also analyzed, and all the findings that we got from the pathologically staged tumors were validated at clinical staging. The T component is the most complex. It has many descriptors. It has tumor size, endobronchial location, atelectasis, and then all the invasions of the surrounding structures, chest wall, mediastinum, diaphragm, and so on. So every descriptor was analyzed individually to see if it was well assigned to the T category that it had the 7th edition. And these analyses were performed in 5 different populations, 3 populations of tumors pathologically classified, the most refined tumors with N0, M0, R0, which means completely resected, but then also in the second population with nodal disease, and then in the population of patients with tumors incompletely resected. And the same was repeated at clinical staging in tumors with and without nodal disease. These analyses generated hundreds of survival curves, and this slide shows the summary of all these analyses. First, and probably most important in this edition, is that tumor size has more relevance than we thought in previous editions. In fact, now tumor size is a descriptor in all T categories. There is no change in visceral pleural invasion, although we saw in this edition that PL1, that is invasion up to and transgressing the elastic layer of the visceral pleura, has better prognosis than PL2, which is transgression of the whole depth of the visceral pleura and also invasion of the lung surface. But this is a pathological finding, so we have it for postoperative prognosis. We cannot validate this clinical staging. Another 2 important findings is that endobronchial location closer to the carina, less than 2 centimeters from the carina, which was T3 in the 7th edition, now was found to have the same prognosis as T2, that is endobronchial location beyond 2 centimeters from the carina. And the consequence of this endobronchial location, which is atelectasis, either partial or total lung atelectasis, has the same pattern. So total atelectasis has been found to have the same prognosis as partial atelectasis T2. And we also confirmed in this edition that the invasion of the diaphragm has worse prognosis than we thought in previous editions. This had already been published by individual institutions, but we could prove it here with an international database very solidly. And finally, we also saw that this descriptor, mediastinal pleura, was rarely used, and actually the 4 lung pathologists that we have in our committee could not remember a single case of lung cancer exclusively classified by mediastinal pleura invasion. So what we did was to reclassify all these findings into this. You have it in the category there. The 3 centimeter cut point still separates T1 from T2 tumors, but when we analyzed tumor size centimeter by centimeter, we saw that from less than 1 centimeter to 5 centimeters, every centimeter counts, and every centimeter separates tumors of significantly different prognosis. So for T1, there are 3 categories, T1A, T1B, and T1C. For T2, we have 2 categories, T2A, T2B, and then those tumors greater than 5 centimeters and up to 7 are T3, and those larger tumors which were classified as T2 in the 7th edition were upstaged to T4 because their prognosis is more similar to T4. Bronchial location and atelectasis and total atelectasis was reclassified as T2, and diaphragm was upstaged to T4. You can see the graph on your right, how well survival curves separate. There are 7 prognostic groups based on the T categories of the T component. One important finding here is that just by upstaging tumors greater than 7 centimeters and diaphragmatic invasion to T4, there is a clear separation between T3 and T4, which was not found in previous editions of the TNM classification. There are newcomers into the playing ground. In the 2011, adenocarcinoma in situ and minimally invasive adenocarcinoma were defined. In 2015, the World Health Organization accepted these new tumors, and we had to find a name, a code, to include them in the TNM classification. The decision was to call adenocarcinoma in situ TIS, but adding in parentheses AIS to differentiate it from squamous cell carcinoma in situ. And T1MI will be the code for minimally invasive adenocarcinoma. There are other important recommendations in the T component. The first one is how to measure tumor size when we have a part solid non-mucinous adenocarcinoma like this one here. You see there is a halo granular opacity surrounding a density here. Well, if this is a cancer, then the tumor size that counts for the T category is the size of the solid component, which translates usually into the invasive component when the pathologist looks at the tumor under the microscope. So for the clinical size, it's the solid component size. For the pathological size, is the size of the invasive component. And also, up to now, the TNM classification was very liberal at indicating how to measure tumor size. The only rule was that one has to register the greatest dimension of the tumor, but it does not specify how to do that. Now I think that nowadays most patients with lung cancer who will undergo radical therapy, be this surgical or chemoradiotherapy, have a CT scan. And if there is a CT scan, tumor size must be measured in the lung window. But as you can see here, the same cut, the same side, the same slide is T2B in the mediastinal window and T3 in the lung window. So the mediastinal window may underestimate the real tumor size. So the rule is to measure in the lung window. The N component has not changed. You see here the graphs for the clinical and the pathological survival of the four present categories. There is no need to change them. They work very well. They separate groups of tumors of significantly different prognosis. The nodal map has not changed either. No map is perfect, so there are flaws in this map. The map is just a guide. It's just a way of coding the location of the lymph nodes. But then every patient is different. Sometimes you don't find nodes where you should find them, and you are a little bit amazed, but no problem. I think we have to have the discipline to use this map in order to gather, to collect prospective information, to find the flaws and the limitations of this map to improve it in the future. One important finding here is quantification of nodal disease. We already did that for the 7th edition, counting the number of involved nodal zones. We've done it with the nodal stations here, and the main thing is that the more lymph node stations that are involved, the worse the prognosis. And you have here in the left lower square all the 5 possibilities: single N1 station, multiple N1, and so on. And you see how the curves separate, except for multiple N1 and single station N2 without N1. These two situations have the same prognosis. So the 5 situations really result in 4 prognostic groups according to the amount of nodal disease. So for the N component, the decision was to keep the present descriptors. These subcategories, according to the amount of nodal disease, could not be validated clinical staging and therefore could not be used to subdivide the present N descriptors, but they are important clinically speaking because we can refine postoperative prognosis of those patients whose tumors have been removed and have nodal disease. They can also be useful to stratify future clinical trials on postoperative therapy for nodal disease. The M1A, that is intrathoracic metastases, have not changed. You see there the four descriptors of M1A disease defined in the 7th edition. They are all grouped in a similar survival curves, and also median survival are very similar. So there is no change. But for the M1B, extrathoracic metastases, there are new interesting findings. You see here in the graph M1A for comparison, that has exactly the same prognosis as single metastasis in the extrathoracic organs. And then the green and the yellow graphs show different things. The green is multiple metastasis in one organ, and the yellow is multiple metastasis in many organs. They both have the same prognosis, meaning that it is more important the number of metastases than their location. So for the 8th edition, we keep the M1A as it is. We redefined M1B as single extrathoracic metastasis, and we defined the new M1C as multiple extrathoracic metastases in one or several organs. For the stage grouping, I really recommend you to read that paper. It really shows the rationale that we followed to finally arrive to this table. We actually assessed 7 or 8 different models to define the stage grouping. It might look complicated, but it's not complicated. Just stage 1A has been subdivided into 1, 2, and 3 to accommodate the new T1A categories. Only the smaller T2s are now 1A. All the N1s remain in the stage 2B, except for the larger tumors T3 and T4, which are a different type of tumors. N2 disease still is stage 3A, except for T3 and T4, and we have created the stage 3C for T3 and T4 N3, because it's really different to have one of these tumors with N3 disease or T1A N3. And for the M component, we have divided stage 4 into A and B. Stage 4A includes intrathoracic metastasis and single extrathoracic metastasis because they have the same prognosis, but they are different anatomically, and TNM is pure anatomy. And we have redefined stage 4B for M1C, several extrathoracic metastases in one or several organs. You can see how the graphs separate very well, except for the graphs clinical staging for 3C and 4A, the same survival, but they mean different anatomic extents of the tumor. Stage 3C is locally advanced tumor, stage 4A is metastatic. There are other recommendations. This is a difficult situation, how to classify lung cancers with multiple lesions, and this has been done by separating these possibilities into 4 disease patterns. Multiple primary tumors, for which the ISLC recommends 1 TNM for each tumor. Separate tumor nodules does not change. T3 for the same lobe, T4 for another ipsilateral lobe, M1A for contralateral lung. Multiple adenocarcinomas with GGO features or lipidic features are classified by this old rule in the TNM, using the highest T and parentheses indicating the number of lesions, or M for multiple, with 1 N and 1 M for all tumors. And the rare pneumonic type adenocarcinoma is again classified according to the lower location of the tumor. In summary, for this 8th edition, we give more relevance to tumor size. We have reclassified some T descriptors. We have validated the present N descriptors, but we have also recognized the importance of quantifying nodal disease because it has prognostic relevance. We have 3 metastatic groups and more stages for better prognostic stratification. Therapeutic implications, there are some. We know now that every centimeter counts, so we have to be careful when we decide to follow up small nodules that are not diagnosed. The patient and the doctor must know that small increases in size may mean worse prognosis. We have identified these tumors with worse prognosis, larger tumors with nodal disease. Surely, upfront surgery for single stage and N2 will be discussed in the future, but with this 8th edition we can stratify better metastatic disease. This is important for future clinical trials. However, just mere changes in taxonomy do not mean automatic changes in therapy. Therapy comes from properly designed clinical trials and not from taxonomic changes. In conclusions, this 8th edition has the virtue to increase our capacity to refine prognosis, to improve tumor stratification. It will certainly prompt future disease. There are no changes in the N component, but we have this important information on the prognostic relevance of quantifying nodal disease. These rules on how to classify tumors with multiple lesions, if followed, will facilitate homogeneous tumor classification. And as you have all said before, this TNM classification should be used from 1st January 2017. You probably have heard that the American Joint Committee on Cancer has delayed the use of this classification to the 1st of January 2018 because the AJCC and their partners have not their software ready to use it. But for the rest of the world, in Japan, in Europe, and in the Spanish society, the date is 1st January 2017. Thank you very much for your attention.